Hi, good afternoon, everyone. Thank you for joining today's network call, the second of the Stepping Up network calls. My name is Nastasia Walsh. I'm a program manager at the National Association of Counties. I'll be facilitating today's network call. For those of you who this is your first contact with Stepping Up Initiative, this network call is part of the national initiative to reduce the number of people with mental illnesses in jails. Stepping Up is the result of a partnership between the National Association of Counties, the Council of State Governments Justice Center, and the American Psychiatric Association Foundation. And we receive generous support from the U.S. Department of Justice, Bureau of Justice Assistance, and other private sponsors in order to fund the initiative. Some really quick logistics. You can use the questions box at any time to type in questions about what we are covering, or if you're experiencing any sort of technical difficulties. If you're having any technical problems, we'll respond to you privately through that questions box to help you resolve the issue. But if it's a content-related question, I'll read the question on your behalf when we come to that part of the call. So please feel free to start submitting questions at any time. And I know that we had a lot of outstanding questions from the last webinar that we had last week, and so we'll be able to answer some of those today as well. So please feel free to start entering in any of those questions as soon as the speakers are talking, and we'll do some a lot of Q&A after the first presenter. Since this is the network call, I want to give a quick update on Stepping Up and where we're at as we start to approach the 2-year anniversary of the initiative, which is in May. As of this morning, we have 355 counties across the country who have passed a resolution to join. The most recent resolution came from Athens, Clarke County, Georgia, which is a county with a population of around 125,000 people. So we're really excited to welcome them to the initiative and to the network. The Stepping Up counties, these 355 counties, we represent more than 125 million county residents in 43 states. So about 40% of the U.S. population. So we're really seeing the impact grow across the country, and thank you to all of you for joining the initiative. You can still join the initiative, and like I said, we're getting more and more every day. You can see the list of counties. This is, a map that I'm sure is very small for many folks to see where their county is. But you can also get a state-by-state list of all the counties who have joined on the website, stepuptogether.org. And on that website, if you click on the What You Can Do tab, you can also get a template resolution if your county is one of those that has yet to join the initiative. And if you did pass an initiative and a resolution to join, and you don't see your name on that list or up here on this map, please be sure to email us and send us a copy of that, and we'll make sure that you're included as part of the initiative. 2017 has been a really busy year for the initiative already. As we talked about on the last network call, in January we held the California Stepping Up Summit, and the Stepping Up partners gave presentations in all over the country: San Antonio, Oregon, Tennessee, Pennsylvania. We also conducted a seminar with the National Sheriff's Association, and we'll be doing another one with the association in June. This month we will be at the American Jail Association in Orlando, and we were also at the National Council on Behavioral Health Conference in Seattle this month, actually last week. Next month, North Carolina and Oregon are both holding statewide Stepping Up Summits, both on May 9th. So I hope folks in those states will get in contact with their state association of counties to be able to participate in those events. And we'll be presenting at the American Psychiatric Association's annual meeting in May in San Diego for those of you who are attending. As you know, this year Stepping Up launched a new series of webinars, these network calls, as well as conference workshops. We're going to be doing some peer exchanges, small group networking opportunities, and other peer learning activities that are for Stepping Up counties. These monthly webinars and the network calls are really going to be the place for you to get the latest research and strategies for you to see what's going on around the country and learn from your peers about how to reduce the number of people with mental illnesses in your jails. We've got our network call today, and then the next webinar and network call series will be in May with the topic of question 3 of the 6 questions county leaders needs to ask. And those webinars will be on May 11th, and the network call will be following it on May 17th. So you can please go ahead and get online and register for those. You can register at stepuptogether.org/toolkit, and we'd love to see you on those webinars next month. Also, we started the quarterly small networking group phone calls, which are for 3 different groups: rural counties, mid-sized counties, and large urban counties. And we've had some great conversations so far. We'd love to have more counties join. If your county has passed a resolution and you're not already involved in some of those calls, please feel free to email me, and I can add you to whichever one you find to be the most appropriate. We plan on doing the next series of calls in June, so please feel free to email me about those, and we'd love to have more opportunity for counties to engage on the topics that you really want to discuss with some of your peers of like-sized counties. So we want to make sure you knew about that. Also, one last thing, as you heard on last week's webinar, the U.S. Department of Justice Bureau of Justice Assistance has a solicitation out right now for the Comprehensive Opioid Abuse Site-Based Program. This is a new solicitation as part of the Comprehensive Addiction and Recovery Act, and the solicitation applications are due on April 25th. So you have plenty of time to apply. There's 6 different categories, so please feel free to take a look. The link that's posted there on the website goes directly to that solicitation, so you don't have to go looking for it. Really encourage folks to look at that. We know that substance use and opioid use especially is really something that's impacting our counties right now, and so I would encourage you to look at that opportunity and see if it's something that your county would be interested in. Again, it's due on April 25th, so you still got a couple of weeks to get everything mobilized and turn that stuff in. So as some of you heard on the last network call, really one of the main purposes of these network calls as opposed to the webinars is to provide an opportunity for you, the participants, to connect with speakers from different counties across the country who are doing some innovative work on the topics covered during the webinar. So I think the webinars are great for having a lot of information to share with you, but we didn't really have a lot of time for Q&A, and I feel like that usually happens because we're trying to throw in so much content for you. So these network calls are always going to follow the webinars, feature some of the same speakers, so you can follow up with them on the things you were hoping to know more about during the webinar. And then on today's network call, in addition to our presenters from last week, we have brought in Dr. Michael Schaefer from the Virginia Department of Behavioral Health and Developmental Services, and he's going to talk about some options and implementation considerations for mental health screening tools in jails. Dr. Schaefer is a licensed clinical psychologist and a board-certified forensic psychologist from the American Board of Professional Psychiatry. He's employed as the Assistant Commissioner for Forensic Services at the Virginia Department. And in this role, he oversees and manages forensic operations in state psychiatric hospitals and community-based forensic programs. He oversees the sexually violent predator evaluation and treatment program that's operated by their department. He's also been instrumental in improving the system by which not guilty by reason of insanity acquittees are treated in their state facilities. And he's helped to create a robust outpatient competency restoration treatment program and has really been involved in expanding criminal justice diversion programs for individuals with behavioral health needs throughout the state. So we thank you for being here, Dr. Schaefer, and the floor is yours.
Great. Well, thank you all for coming. This is a topic that's so close to my heart and importance, I think, to all of us in terms of we all know that the national statistics are showing us that there's an overrepresentation of people with behavioral health challenges in the criminal justice system. And rather than my picture at the beginning, you should have just seen a small cog, because I'm a small cog in a larger wheel of a large group of people who are working together on this project. So I just happen to be the one who has to talk today, but by no means am I the only one working on this. Virginia has made a big commitment to addressing this issue, and for the last 10 years has done a lot of robust work in addressing it. So let's go to the first slide. In terms of screening. So one of the things we've looked at is, well, how can we better identify people with behavioral health challenges in the jails? We have 63 jails, I believe, and we're trying to figure out, well, how do we know how many people with behavioral health challenges are in each jail? And what we found when we surveyed all the jails is they all do screening and assessment in a very different way. And what we have really been pushing is that standardized screening is a best practice that should be used in all jails. And we've had different work groups have collaborated with us on this, and we have a fairly good consensus agreement that screening is a best practice that every jail is encouraged to use. Obviously, from a financial perspective, it makes sense to use screening and to train correctional officers or booking officers or classification officers to do the screening, because that way you're not using your scarce mental health resources to do the screening of 100% of the people. And the research has found that trained correctional officers, in fact, are very reliable screeners, and they can reliably identify people with behavioral health challenges. The contrary to that is what we've, when we were looking as a state, when we looked at studies when they were doing screening but using sort of a homemade mom-and-pop developed screening tool, there was an error rate of almost 67%. So using a standardized validated screening tool became very important to us and a best practice that we're pushing forward. So let's go to the next slide. So then we tried to figure out, well, what tools are out there and what should we, as a state encourage. And so we did a lot of research on what's currently available. And again, we wanted things that were available, cheap, low cost, easy to administer, and had been replicated. So it wasn't just, Mike Schaefer had developed this tool. He wanted something that had been developed and had been replicated to show that it was actually reliable in identifying people with behavioral health challenges. And you can see the list of tools that we found out there. Each of them were found to have pretty good sensitivity rates, meaning they accurately identify true positives, and also good specificity rates, meaning they identify true negatives. So they are pretty good at doing what they're designed to do. And our goal, obviously, is to balance the true positives with the false positives. So if you get too many false positives, you're using your resources with the mental health clinicians having to do a secondary screening on someone who may not really need it. But you also want to minimize your false negatives, because you don't want someone who has a behavioral health challenge not being identified, not getting services, and decompensating in the jail. So let's go to the next slide. And that just says what I just said. And so we're really trying to balance, the true positives with the true false negatives. And we were looking for a tool that would do that. So we go to the next slide. So then we looked at, okay, so all these tools that are out there, what are the pros and cons of each of the tools? We, for a long time here in Virginia, have been encouraging the use of the Brief Jail Mental Health Screen, that's the BJMHS, for probably about the last decade. We've had jails, encourage jails to use that. We've had burn justice assistance grants that have used those screening tools in different jails. And it's known to be a fairly good measure, and it did replace an earlier measure. We then looked also at the correctional mental health screen for men and for women and the EMHS. And the things we liked about them, they are brief, and as I said earlier, that was one of our criteria when we're looking at a tool, is that it has to be brief and easy to administer, and that it can be administered by correctional staff, because like many of you, probably your jails may have one clinician in the jail, and if you're tying that person up with doing all these screenings, you don't have time for them to do the more in-depth evaluations they need to be conducting. So these tools met our needs in terms of they could be done by correctional officers. Again, we found that the brief jail mental health screen was really good and robust at identifying males, but the later research was finding it wasn't quite as good with females as it was with males. And so that raised some concerns for us. We did also look at the JSAT, but our concern with that was it had to be administered by nursing staff or psychology staff, and again, many of our jails just don't have a ready supply of those kinds of staff members, and so we ruled that out on that basis. And then the final two bullets, you can see, well, the brief jail mental health scale is 74% accurate with males, but only 55% accurate with females, whereas the correctional mental health scale is about as accurate for males, but is more accurate with females. So we looked at those figures. So we go to the next slide. As I said, we've long encouraged this. We've done some grants with this. We're unique, or I think we're unique in that every year we do a survey of all the jails in the Commonwealth, and they do a point-in-time survey in June or July every year on the prevalence rates of mental illness, and we ask questions about screening and assessment. This is a survey that's administered by the State Compensation Board, who funds our jails, and what we know is that 51 of the 59 jails reported they in fact do screening. So we know it's happening in most places, but not in all. And then what we also found was about 50% of them were already using the brief jail mental health screen. So that was a factor we were considering on a statewide basis in terms of if we're going to implement screening statewide. We already have 50% using one screening tool. That might be a good tool to keep in terms of you're not having to retool the staff. You're not having to train all the new correctional staff how to use it, because at least half the jails already are using it and presumably know how to use it. And then sort of coinciding with this, we have a Center for Behavioral Health and Justice, which is a center of excellence here in Virginia, that had an advisory group that was recommending standardized screening, and we also had a transformation team from our commissioner who was also recommending screening. So all these sort of forces coincided with us then moving forward with the next slide, which we'll talk about where we're going forward in Virginia. So we have agreed as a group that using standardized screening is a best practice, and we've got pretty good agreement by the local jails and the regional jails that yes, they agree this is a good practice. What we're recommending is the use of the brief jail mental health screen for men, because again, 50% of our jails are using that tool. What we know in Virginia about the arrest rate is about 80% of people in jail are males and 20% are females, and so we're already capturing a good amount of people, and so we don't want to switch to another tool. But we are recommending to our jails that for women, they use the correctional mental health screen for women. To sort of support our efforts, last year, our governor gave $2.5 million to our Department of Criminal Justice Services, which is our lead criminal justice service agency in the state, for pilot mental health programs. And what they made as part of the grant solicitation is those jails that got the grants had to agree to use a standardized screening tool. So it was a way to incentivize jails to use that. And so we did have 6 pilot projects going that are using that standardized screening and assessment to move forward. And then finally, this General Assembly session, our General Assembly passed in the budget language, the bullet you can see here, that really empowers the commissioner to designate a tool for the screening and assessment of people with potential behavioral health problems in jail, and that the jails are to use that tool. So as a state, we are working on a training program right now to train jail officers on how to use the tool, but our General Assembly has set it up now that the jails will be required to use a standardized screening tool, and it will help us as a state get a better handle on how many people with behavioral health challenges we have in our various jails. So if we move to the final slide, so when we were looking at, so what do we use, and both the brief jail mental health screen and the correctional mental health screen for women and men are both free, and they're in the public domain. So that was really important to our partners, the jails, because we didn't want to have a unfunded mandate to them to use something that they would have to spend money on. We do recognize that it's not fair just to tell them, here, start using this tool, that we have an obligation as the Behavioral Health Authority to provide training. So as I said, we're developing that training, and we'll be rolling that out in May. The training is relatively short. It's about a 2-hour training. It's a basic orientation to Mental Health 101, how to do some basic interviewing, and then how to actually use the tool and score the tool. And we've developed that. We'll be using a train-the-trainer model, and then we will also be doing web-based training. So all this is culminated because of a partnership between the state government and then local governments through our Center for Behavioral Health and Justice. We've really worked to not have it feel like it's the state mandating to localities what they do, but really a collaborative approach, a recognition that this is a problem for all our localities, and looking at what the state can do to facilitate the localities implementing this best practice. So I'm very thankful to the partners we had working on this, and it really seems to be culminating now into some really exciting new times in terms of being able to have the same screening tool in every jail across the Commonwealth and being able to get a good sense of how many people's behavioral health challenges are in each of our jails. So that's all I really had to say today.
Great. Thank you so much, Dr. Schaefer. I appreciate it. It's good to hear, sort of the state's role in assisting counties on this. And, I'll be interested in hear a little bit later, maybe when we get into the discussion about, how you're involving counties in helping to make the decisions around these statewide tools. So we can talk about that a little bit later. So we appreciate you being as part of this. And now, I want to, before we jump into Q&A, for Dr. Schaefer and the other speakers, I want to make sure that we introduce the other speakers who are on the line. All of our speakers are welcome to join in on the Q&A, and audience members are welcome and encouraged to direct any of your questions to any of the speakers who are going to be speaking here or who were also on the previous webinar. So please feel free to direct or throw out individual questions, and you can start throwing out those questions now if you'd like. So really quickly from our previous webinar, we have Sarah Wurzburg, who is the Grantee Technical Assistance Manager for Behavioral Health at the Council of State Governments Justice Center, who spoke about the strategies from question 2 of the 6 questions report. We also have Bruce Barnard, who is the consultant for the reentry program in Champaign County, Illinois, and Mike Brower, who's the reentry director for the Douglas County Sheriff's Office in Douglas County, Kansas. So welcome back to all of you. Thank you for being back here. So to kick off the discussion, I'd like to ask each of the speakers one question and get their responses, and have folks sort of jump in with their question as well. And we have, like I said, we have leftover questions from the last webinar as people are throwing their questions in. So why don't we start with Sarah? Sarah, and for the rest of the folks, what do you see as, or what are you seeing as the biggest challenge with implementing an efficient screening and assessment process for mental health and substance use disorders? And how are you seeing folks overcome this challenge, or how are you planning to overcome this challenge? So Sarah, why don't you go first?
Sure, thanks, Nastasia. I think the first really huge step of this is really getting people on the same page from behavioral health and across this criminal justice system, from law enforcement to sheriff's department or jail administrators, as well as probation and parole. And I think the first big challenge is actually making sure that you have system-wide definitions for mental illness and for co-occurring substance use disorders. So making sure that you're actually talking about the same thing across different places within your system. So I think that's kind of the first big step. And then once you have those definitions, I think we move on to the issue of being able to track who has mental illness and co-occurring substance use disorders in your jail. So whether that starts with doing a daily count to see on one day in your system who actually has screened positive for those things within your system, and then moving to being able to ideally have real-time tracking of people with mental illness and co-occurring disorders in your jail, so you know every day how many people actually have those additional needs. I would also say that information sharing across the agency for behavioral health information, pretrial risk, and criminogenic risk assessment, that is often a huge challenge to make sure that all the partners can be on the same page to be able to address people's risk factors and their behavioral health needs. And then continuing to be able to track the information across. So if someone is in a jail and they move outside of the jail to a community-based behavioral health provider, for example, being able to track the referrals and the access and retention and treatment. So once you kind of know who's in your jail, it then leads to the question of what services are offered. Are there diversion opportunities, either, you know, pre-booking diversion before they even get to jail or post-booking diversion? Are there pre-trial options for screening and assessment? What services are actually available to sentenced populations who may be in your jail? Are there services for mental illnesses and substance use disorders? And then for folks that are moving on to probation caseloads, are there options for referrals to services? So I really think it's a lot of collaboration, getting people on the same page to be able to define the mental illness and substance use disorder, being able to track who's actually in your jail, the information sharing, continuing to be able to regularly track and update that information and get it as close to real time as possible. And then what services can you actually offer within your correctional facilities as well as in the community?
Great. Thank you so much, Sarah. Appreciate that. That was a good sort of, overview of some of the stuff we talked about and, really quick on, how people can address some of those challenges. So thank you. Bruce, why don't you go next?
Okay, thank you, Nastasia. And I'm going to kind of echo what Sarah said about buy-in as really being the most significant challenge. I mean, as anybody out there knows who's starting to work on these issues, there's a lot of things to work through in terms of confidentiality and processes and who's going to do the screening and which tools are we going to use and what technology are we going to use to track the data and share information. But those are all questions that you can reach out to other counties. You can talk to technical assistance providers about how those challenges can be taken care of. The one thing that really has to happen county by county, and there are no shortcuts, is that stakeholder involvement. And for us in Champaign County, it really came down to getting the behavioral health providers, talking to the corrections staff, talking to the health providers, the hospitals, and really trying to understand what it was we were trying to accomplish for the folks with mental illness and substance use disorders in our correction system. What were the outcomes we were looking for, and why was this screening process so important? And I remember a conversation we had with behavioral health providers who were working in the jail, and they were like, but, we're doing a great job. We, have these wonderful relationships. We check the jail roster to see if people are currently receiving services. We are responding to everyone that the jail staff identifies. But what it came down to was we really didn't have a way of knowing through an evidence-based tool that we were capturing everyone. And once we kind of really sat down and talked about that and talked about how important that was for us to measure our outcomes, we began to see people understand the need to invest in this and to really make it happen.
Great, thank you very much. And Mike Brower, since we have two mics on the phone. Mike?
Yeah, well, thank you. I'll just reiterate what Sarah and Bruce said. Definitely getting buy-in is a key piece, and then when those folks do buy in, is clarifying what does this information mean, and specifically for looking at screening tools, it's more about clarifying what it doesn't mean, and that it's not an assessment tool, it's not a diagnostic tool. It is nothing more than a way for us to identify individuals who need further assessment. And that was a key piece with our staff to understand. But I think for us, one of the big pieces has been, what do we do with this information once we have it, and how does that relate to how we serve the people in our jail? And so specifically for us, we wanted to make sure that we had this information, we smoothed out the transition for them back into the community. And so that then we had to involve the DA's office, the city prosecutor, our community mental health center, and then our substance abuse agencies to be able to build it, begin to build bridges from the jail into the community for services. And we had this idea once we started doing screening and we started identifying individuals. What we found is that, typically with people getting engaged in the community, it takes a few weeks for someone to obtain mental health or substance abuse services in the community on a normal basis. But when a judge is allowing someone to leave custody to seek services in the community, the judge's expectation is not that it will take a few weeks. The judge's expectation is that they'll receive help immediately. And so we had to work with our partners to make sure that we are able to meet that expectations. And in some areas we're still working on the speed of that process. So that was kind of one piece that we didn't see up front that we've definitely learned on the back end and has definitely been a challenge for us. But with having partners on board and with the same mission, we're having some success there.
Great, thank you. Yes, I'm sensing a theme here on collaboration from folks, and I think that's something that we see a lot, is that's why it's such an important first step for getting these things started, is that collaboration piece. Dr. Schaefer, do you want to talk really briefly about what you're seeing as some of the challenges across the state and Virginia jails?
Sure. I think the same things that everyone else said earlier. I sort of want to phone a friend. They all had great answers. For us on a statewide, part of the problem is you're dealing with such divergent counties, jails with different challenges, different staffing, different funding, that it really, the one-size-fits-all is really, really hard to make work, because there's always reasons why things can't work. And it's hard to get, a county alone is really hard to sort of get everyone to the table and agreeing, but when you're dealing with 67 different, 63 jails, different personalities, and we have 40 different community service boards, which are our outpatient behavioral health providers, it's really hard to get some consistency. And that's why we were really trying to look at something that was easy, incremental, and we're really looking at this challenge. This challenge is so huge that we're trying to break it down into small incremental bites of things we can do incrementally together, collaboratively, that's going to further both from the behavioral health, our goals, but also from the jail's perspective, their goals. And so it's taken many, many years of work, but I think we have done a lot of that collaboration, a lot of the defining what it is we're doing, a lot of educating about, what screening is and isn't, but similarly having jails educate us behavioral health people about the realities of the operation of jail. And I think that has really gone a long way to us being well prepared to take the next step. To really trying to look statewide, how we can really push initiatives. We were very lucky in that we were early involved in the cross-systems mapping initiative starting back in 2008. And I think we mapped like 80% of the counties in our Commonwealth. And so we have sort of this experience and this muscle memory of coming to the table, working together between criminal justice and behavioral health. We also had a really large push on our CIT crisis intervention team initiative. We've got 37 teams in the Commonwealth right now. And so that level of collaboration over the years has really, I think, strengthened our working relationship and an understanding that we're not pointing fingers at each other, but that this is really a vested interest in all of us, and that we can work together rather than blame each other. If we work together, we can actually make some positive steps towards changing the problem. So that's really how we've moved forward. It's not over yet. As someone earlier said, screening isn't really a diagnostic tool. It's just sort of in and out kind of tool. The next question is, so then what do you do after that, and how do you get the resources into the jails to actually be able to do that diagnostic assessment? And who's going to pay for it, and whose responsibility is it? But I think, again, breaking down the big challenge into small incremental steps is really helpful to really get some positive successes without sort of being overwhelmed by the largeness of the problem.
Mm-hmm. Great, thank you. Thank you for all of you for your comments and for the work that you all are doing on this issue. I think, Dr. Schaefer, as you were talking, we got a question in about, was there strong buy-in by county criminal justice systems in Virginia? And if so, how was that achieved? How are you getting the, the counties and the county jails to really buy into what you guys are trying to promote in the state, and really, what is sort of the law of the land now, and how you worked, sort of with counties on that?
I think we have good county buy-in. I haven't asked every county, and I'm sure there are some counties that are saying, oh, no, this is, something we don't want to do. But the way we approached it is, again, we've had several different work groups. We had our Commissioner's Transformation Team, and then we have the Center for Behavioral Health and Justice. And on those, we have work groups, and we brought leaders from the criminal justice side of things. So we had the president of the Virginia Sheriff Association, and we had currently the president of, we have regional jails here in Virginia, so the president of the Regional Jail Authority, who don't necessarily speak for their members, but sort of bring the concerns of the members and share back with the members what we're doing on a statewide basis. And so we, and similarly, we had representatives from the behavioral health. As I said earlier, we have 40 different CSVs, and but we had representatives from them, so that we had good representation and really sat and met week after week, or well, actually it was probably month after month after month for the better part of the last several years, listening, hearing, problem solving, and not trying to make it not feel like we're shoving anything down people's throats, that it was really a collaborative process, that it was really a sensitivity to the challenges that our jails are facing. So it's not just mental health saying, do this, jails, you're responsible, but it's really what can we do together. And I think that really did help foster the collaboration. Again, come July 1, we'll probably hear some more, because there probably are some jails where this will be a particular challenge, and our response will be, well, how can we help you overcome that challenge? And being sensitive to the day-to-day challenges jailers face. And when 1 out of 4 people in your jail has a mental illness, that's a particular, it's very challenging, it's very expensive, and so being at least attuned to that, I think will go a long way towards us being able to work together to figure out, well, how do we overcome that, and how do we work together to go back to our General Assembly and advocate for what we need next to make this really a successful process.
Great. Thank you very much. And we're seeing a lot of folks are already putting in their questions. So as everybody, I think, on the phone knows, if you see, or on the webinar knows, the questions box, please feel free to type in your question. I'll read the questions aloud as with our speakers. We did get a question that I think, maybe Bruce and Mike Brower, maybe you all want to answer this. Maybe we'll start with Bruce. But how did your community determine the agreed upon definition of mental illness and co-occurring substance use disorders? You want to start, Bruce?
Sure. We were working on that with a planning group, a large planning group, and decided to put together a smaller group that included myself and the behavioral health providers in the community and a correctional officer to kind of talk about where we could go with that. And really it came down to coming up with a definition that would allow us to ensure that we had access to services. Illinois is a Medicaid expansion state, so it was important to us that we be able to provide counseling services and assessment services and psychiatric services to those folks that we identified as our target population. So we really used the state definitions to pay for services, and we looked at obviously the DSM and the diagnostic criteria, but we really didn't try to reinvent the wheel. We used some language from the National Association of Behavioral Health Providers and relied on standard diagnostic kind of language.
Great. Okay. Yeah. Go ahead, Mike.
Oh, sorry. I say this is Mike. Yeah, we're very similar to Bruce. We actually were kind of fortunate that just by pure coincidence, several of us had been working with the Governor's Behavioral Health Policy Council and on a state level, meeting with other facilities across the state and mental health centers. And so we had been talking about doing a survey of SMI people leaving jails and seeing what the discharge rate looked like from jails due to the fact that so few people were able to get into state hospitals here in Kansas. And our premise was that we felt the state should provide the same level of care to people leaving jail with serious mental illness as they would apply to someone being discharged from the state hospital. And so we had already developed or had kind of gone through the process of, well, what should be our definition for SMI. The State Association of Community Mental Health Centers didn't have a real clear-cut criteria for SMI like they do for SPMI, severe and persistent mental illness, which is required for Medicaid here in the state of Kansas. So we actually have been working on that and looked at the American Correctional Association's definition and worked with the University of Kansas, and so we actually have 3 different jails that are doing this same screening tool and utilizing the same diagnosis for SMI. And of course, as we hear about anybody else who'll pick it up, we're going to encourage that we all work together to use the same language. So I think we were fortunate, and we already had a statewide committee that had already been looking at that issue.
Great, thank you. Yeah, I think that's definitely one of the bigger challenges for folks, and I think Sarah touched on this too about how big a challenge it is to come up with this shared definition, and then sort of go from there once everybody's in agreement on how this is, and it helps with data collection and those pieces. So thank you both for sharing that. I appreciate it. So we had sort of a specific question about the tools, and I thought, maybe Sarah or Dr. Schaefer might be interested in that. I'm going to sort of summarize this person's comment and question, but basically they're using a screening tool that we didn't talk about on this webinar, but it is basically having a really high positive rate, so about 90% of people screened are recommended for further assessment, and that's just not really feasible given the resources in that county. And do you have any experience with this issue, or should they be using a different tool that could better serve the purposes that they're using that for, recognizing that once a person screens positive for a mental illness or a substance use disorder, you want to do that full assessment, but I guess their sort of concern is if their screening tool is looking at 90% of the people screened have mental illness, we've seen that seems a little unlikely. So maybe we want to talk a little bit about false positives and validation of tools. I don't know, Sarah, if you want to start and sort of address that question.
Sure. Well, I'm not sure what tool the county is utilizing, but I think one of the flags that I would have initially is, what does the training look like for the individuals who are administering the tool? Is this a self-administered tool? Is this something that a classifications team or correctional officer are administering? And do they really have the right training in order to be able to successfully utilize the tool? Because it could be the tool, and it could be a validation issue. It also could be the training that was provided to the people who are administering the tool, that they're maybe not clear on, how the instrument is supposed to be utilized, whether that be a self-assessment or them asking questions to the person. So I think it definitely is a flag to look at your training that you've been doing for administration. So that would be the first thing that would come to mind. You can also potentially, if it's not a validated tool, consider using one of the free validated tools like the ones that Dr. Schaefer mentioned, and you can potentially choose to do kind of the tool for a certain number of people over the course of a day or a week, and use a couple of different tools and see if you're still getting the same percentages. So you could try to do some level of comparison to see if it really is that tool or whether, you know, it's your population. But it sounds like there's a validation issue, and it also sounds like probably a training issue.
Great, thanks, Sarah. I didn't know, Dr. Schaefer, if anybody else had any experience or wanted to share any tips on that.
No, but that's a very common concern is, and again, I spoke about the sensitivity and specificity of the tool. You don't want something that over captures people and identifies people as potentially having mental health problems that don't, because then again, you're using your resources. So I'm not sure what the tool is. I don't know who produced it, but you know, if it was produced by one of these companies that give you sort of this case management software or classification software, you may be able to talk to them to figure out if it has known, you know, false positive rates. And but I would consider looking at one of these free tools. Again, the only really cost is sort of integrating it into your classification or your booking system. But these tools have been found to not have a too high of a false positive rate. So even though there may be a little cost of switching to a different tool, you're going to save it in that you're not going to have all these people have these follow-up assessments.
Mm-hmm. And the individual followed up by saying it's the GAIN, they're using the GAINS short screener. If either of you knows anything about it.
I'm not familiar with that one.
Okay. Okay. Great. Well, I think this, you know, also leads into a question that we got about, and maybe Bruce and our county folks want to comment on this. Can you talk a little bit about who in your jail conducts the screenings versus maybe these follow-up assessments, and why is it done this way? You know, what type of qualifications or training are given to the individuals who do the screening? So Mike, maybe we'll start, Mike Brower, maybe we'll start with you.
Yeah, so I've been fortunate enough to be a social worker working in jail for 14 years now. And I know over a couple of different projects, in addition just to this that we've worked on, we've had, well, first of all, I'll say for both jails and similar projects is we would utilize the officers working in the booking area to do this assessment because they're the ones that are doing initial screening for everything. And what we had found is that at various times your quality of asking questions and even sometimes there'll be changes in the rate of people refusing to answer questions will occur, and so you know there has to be constant getting feedback from the officers that are doing the assessment, constant feedback to them as to why we're doing the assessment, how we're utilizing that data, why it is important, because they have a lot of duties to do. They're screening for so many different things when someone is booked into a facility that it's easy to lose the value of something new being important. And to give you an example, a larger county next door to us back in December started using the brief jail mental health screen, and the first like 3 or 4 weeks they had tremendous completion rate. I think they're around 85% of jail bookings were completing the screen. And then all of a sudden there was a significant dip in their completion rate, and they were able to, they've got an excellent database system, so they were able to narrow it down to one shift that was having this huge number of rate of people refusing to complete the screen. And so, you know, that then carried an opportunity where they went in and talked to the officers working on that shift, and, you know, they didn't point any fingers or blame anybody. They just said, hey, I want to make sure you understand why this is important and how we're utilizing this information, and then actually their the completion rate went up dramatically after they had that conversation. And so I think, you know, for us, what we do is we want to just every now and then pop in with our officers. How's it going? Do you like the tool? What feedback do you have for us? And this is how we've utilized that tool to help people. Those anecdotal stories is good for the officers to hear.
Absolutely.
Nastasia, just to add one more thing. Sorry, this is Sarah again. I'm also wondering if there's overrides that the officers are actually doing on the actual screening tool, because I am familiar with the Gain Short Screener, and we do work with a lot of jurisdictions who have had success using that tool. So I think there's also the other question would be is if for some other reason people are saying overriding the results of the tool and saying, yes, this person needs to be assessed, or, you know, I just think that this person may have a mental illness type thing rather than actually utilizing the tool correctly. So I would also take a look at the amount of overrides that are being done.
Great. Yes, very good point. Very good point. Thank you. I wanted to toss it. I know that this question was going to come up, and I sort of anticipated it coming up, and it came up a little bit on the last question too. But I don't know if anybody wanted to jump in on a privacy question. So, what data can community mental health centers share with jails? Do they need a shared database to exchange information? Does anybody want to jump in on that one?
This is Bruce. I'll touch that one a little bit because that's something that we've spent a lot of time talking about in our county, and it's one of the reasons that we really wanted correctional officers doing the initial screening so that when the correctional officer identifies that the person is screened positive on the brief jail mental health screen, that they can alert the behavioral health staff in the jail to do we have like a secondary screening process that determines whether they're eligible for programming and assessments and also does benefits enrollment. So it's one of those things where the confidentiality limitations are really important for the behavioral health staff, but from a understanding the systems perspective, it's also really important that the behavioral health providers be willing to share aggregate data. So understanding that they can't necessarily say without a release of information, did this person receive a secondary screen? Did they go on for an assessment? Were they successfully linked in services? Obviously, that's confidentiality, that's HIPAA information. But what they can do is say that the jail referred 100 people to us for secondary screening. 73 of those agreed to participate in that secondary screening, and X number of those were linked with services and received an assessment. And that's really important information. So I think it's really important for counties that are kind of trying to take this on not to be overwhelmed by the fact that, you know, they can't share, or the behavioral health providers can't share client-specific information, because there is a lot you can do to understand what's happening with the system within the constraints of that. And I come from a behavioral health background, so I certainly wouldn't want to undo that. I think those confidentiality protections are extraordinarily important.
And I would agree with Bruce on that issue we've always dealt with. And one thing, kind of for us, the Kansas state statutes are actually more rigid than HIPAA when it comes to this kind of information sharing. And so for us, as a sheriff's office, that information sharing highway goes one direction. And so we share this screening information with the mental health staff. And we have another local jail who's directly sending the screening information to the crisis team at the local mental health center, along with if someone is released from custody, so that they can follow up as needed. This brings up an opportunity to, I think that one of the important things for me is that having your community mental health center staff inside your building, if you can do it, if you have the support and the finances to make that happen, is just a huge benefit. So we're very fortunate here that we have the clinicians that work in the building are employees of the local community mental health center, and they have the local community mental health center's database here in the building, so they can look up clients to see if they're active, to see what their medications are, to contact their case manager or clinician, let them know they're at jail. And so that has been a tremendous help in improving the speed of information sharing.
I would add, this is Bruce again, I would absolutely agree with that. I think having those behavioral health staff right there able to access the confidential records is a huge, huge step forward.
Right. And we had sort of a related question that's more on maybe sort of the technical side, but what is your mechanism for reporting and tracking on these individuals? Whether it's a portal, or are you using Excel? Do you have paper forms? And then, how often is data transmitted, and who sort of maintains this information in your county? So I don't know if, Mike or Bruce want to start. I'm sure Dr. Schaefer, you're seeing things happen in the Virginia counties as well. So maybe, Mike, do you want to start?
Yeah, so this is one that we've been working through. We have been right now just utilizing a spreadsheet, and that spreadsheet is maintained by our mental health staff. The data collected on that spreadsheet is set by our program evaluator from the University of Kansas. But we are just a short period of time away from actually being that we have had to work with our jail database company called Spillman, and we because we would like to have been able to flag individuals, especially those with serious mental illness, in the system, and we were concerned about confidentiality, and because of the sheer number of people are able to access that information through the jail management system. So what we actually have found is that the medical portion of the jail management system is by user access only, so based on your login. And we're able to now put a flag into the assessment portion of the medical database where only people who need to know that information have access to it. But that's also then going to allow us to run reports that link that individual to demographic information, to crimes, to number of arrests and bookings and so forth. So just on the verge of getting there. A local county that we work closely with next door, they have a very advanced database system, and they've been doing this for a while. And they are actually able to link their jail management database with their mental health center's database. And so they are, like I said, they are immediately sharing this information with their community mental health center in anticipation of people discharging. So it's not easy to keep the data, but it is possible if your facility has the passion to do it.
Great. And I didn't know, Bruce or Dr. Schaefer, if anybody else wanted to jump in about what you're seeing.
Well, this is Bruce. What we actually developed a database for the screening information, more out of just necessity to have that data reside somewhere. And at this point, we do not have an integrated system. We're really only a few months into having that jail screening data available. But what we're doing is using a process of de-identifying data and combining and merging databases to try to get a feel for prevalence and what's happening in our county. But the database that we were able to develop, a faculty member at the University of Illinois did it for us, actually, calculates the scores on the screens and records the demographic data and generates reports. And that aspect of it is very helpful. And I do know that the American Psychiatric Association is working on something like that through the Stepping Up initiative as well.
Yeah, and in Virginia, we are really struggling with the data piece. We're wrestling into how to best capture it. And as you can imagine, again, 63 different jails, with different jail systems, different IT systems. We haven't found the fix yet. Most of our jails do capture the data. A lot of them use Excel spreadsheets, but in terms of now trying to figure out how to gather that data statewide, we are not quite there yet. So I was excited to hear that people are working on this and have found solutions, and maybe reaching out to you all to find out how you've done this.
And on that data piece, we've had conversations with our attorneys, and so has the neighboring county with their attorneys on, is the initial screening is not come under the same level of legality under HIPAA as does an assessment or actual diagnosis. So we are actually we are creating a mental health referral flag that that immediately goes to our staff for people who screen as positive on the brief jail mental health screen. Then we're also, we have a suicide risk screen or flag that is generated by our suicide risk instrument. So those two screens can be seen by, or flags can be seen by staff. And then we are the only flag that we have, which is SMI, that is attached to any kind of assessment or diagnosis, then is seen by people who have the need to know. So we're kind of dividing out what each of these tools provides and how we handle that information.
Mm-hmm. Mm-hmm. Great. We had another, shifting gears a little bit on the topic, but we had a question come in about, what are some of the strategies you've used or seen when you identify someone as having a mental illness or a substance use disorder, you offer them diversion or treatment, but they refuse to accept any sort of help? What sort of options have you seen for people who are medication non-compliant or refuse services once you've identified that there's a problem? I'd be interested to hearing from anybody's perspective here on the call.
This is Bruce. One of the things that we did early on with the behavioral health providers who were providing services in the jail was to make sure that they understood and were trained in motivational interviewing, and put a great deal of emphasis on engagement. Now, obviously, that's not, the solution to everyone who's non-compliant, and being in a jail is an extremely stressful environment. But I think that, again, it's an advantage to having community providers on site in the jail because they're not perceived as being part of the jail. They're perceived as coming in from the outside to help. And in some cases, they have a history with the client. They know them because they've been a client of the organization in the past, and that can be immensely helpful. But, those are just some small things that we've done to try and address that.
Another thing that I would add to that as well is we've seen a lot of jurisdictions utilize peer specialists as well, and they sometimes have more success engaging folks than some of the trained clinicians for the sheer fact that they've been in that person's shoes. So in addition to the motivational interviewing and the in-reach into facilities, we've also had a lot of jurisdictions moving forward with peer specialists doing in-reach in the facilities and who are part of the case management treatment team as well. So I think we've seen a lot of grantees feel like that really bolstered their ability to engage or to re-engage people when they've lapsed.
Great, thank you. I think both the peer support specialist piece in particular was really on the tip of my tongue. So I'm glad you touched on that. Thank you. We just have a couple of minutes left, so I think we have maybe one question. And we, one of the questions that's come up a few times is, if and how you're using Medicaid funding on any of these efforts, whether it's obviously not with the screening tools, but how are you using Medicaid to fund interventions with this population? And so I thought maybe Bruce, I think you had touched on this a little bit in your last presentation, so maybe you want to start.
Sure, and that was something that we were very concerned about, was the potential for changes in Medicaid, because we relied very heavily on it. It is primarily paying for the services that we provide in the community. The services that are provided in the jail are paid for by the County Mental Health Board. Those engagement services, the motivational interviewing, the benefits enrollment, and the screening is being covered with county funds. But the linkage to services in the community, the assessment, the psychiatry, those services are being primarily covered by Medicaid and some third-party private insurance.
I'll just say, this is Mike, I'll just say here in the state of Kansas, our governor has very passionately chosen not to participate in Medicaid expansion, so that has not been an option for us. And as I said last week, the growing jail population, the lack of state available mental health services has really created a public awareness for us, and so it's created a lot of passion here in our community about improving mental health services, and so that has led to our county commissioners being willing to fund these kind of initiatives. And so on one hand, these problems have that we're experiencing have been a blessing in our ability to, I think, improve services and efficiency of services.
In Virginia, we are not a Medicaid expansion state, despite our governor's desire to do so. He did create a program 3 years ago, the Governor's Assistance Program, which is a limited benefit Medicaid type of benefit. Unfortunately, people coming out of jail were not a priority population for that, but the General Assembly this year has mandated we look at that and see if we can link people to services. Another challenge we have here in Virginia is if you're in jail for 30 days, our agencies terminate your benefits versus suspend them, which leads to a break in benefits once you get out of jail. So we are working with our state team, Department of Medical Assistance Services, to look at that policy and practice and see if we can change that. Sort of as Mike was saying, the localities where the local government has really seen this as a priority and they've invested money, we see they have more robust programs than the poor counties that don't have as much of a contribution. So it's really a challenge. But as I said, last year our governor also, with the General Assembly support, did $2.5 million for some pilot mental health programs that are an 18-month pilot, and we're hoping to come back with the results in 2018 to show the General Assembly the benefits of providing the services in terms of decreasing rearrest rates, increasing future engagement and treatment, and hopefully they will fund some more services since we don't have Medicaid expansion.
The other thing that I would add is that we actually recently released a paper called Critical Connections, and it's about getting people living in prison and jails the mental health care and substance use treatment they need. And it's really focused on what policymakers need to know about healthcare coverage and how to access that. So it has some really cool examples of different options for that have been used in expansion and non-expansion states, different Medicaid waivers and things like that. So I think that's also a good tool. There's a couple of really great charts that lay out the options within that document. So I definitely recommend that if people have questions on it, that might be a good resource for you as well.
Great, thanks, Sarah. And where can they find that resource?
That can be found at our website, csgjusticecenter.org, and I can put it in the chat box if that's helpful so people can access it.
Yeah, that'd be great. Thank you very much for sharing that. And thank you to all of you for your questions. I have, just one really quick question that came in, and I'm not sure if any of you know the answer to this. If the correctional mental health screens for women and females and males, if those have any good research behind them for juveniles, or if you know anything about, mental health screening tools for juveniles. I'm not sure if anybody on the phone has that knowledge or not.
Nastasia, this is Sarah. So the GAIN short screener actually can be used for juveniles as well. And there is a battery of screening and assessments that are validated for juveniles for substance use and mental health. Not all of them have been validated specifically on the juvenile justice population.
Great, thank you. And I'm sure there's some information out there, and we can look and see if the person who sent in that, had a follow-up question about that. I'm sure there's some tools out there that we can see as well. So thank you for that. So thank you. Great, thank you, Sarah. I appreciate that. So that's really all the time we have for questions today. We appreciate all of your questions. I think we had a good discussion and good sort of follow-up on this, and thank you to each of our speakers for your thoughts and insights, and Dr. Schaefer for your presentation. You know, I'd be interested in hearing from folks on the phone about their experience with screening and assessment in your own county, so maybe we can launch the poll about what your biggest challenge is. Great, thank you. Maybe we'll show just this one poll if we could show the results. So it seems like some general consensus around, you know, implementing the tools effectively, and then, you know, the information sharing, which we know continues to be a big challenge. And I hope that some of the discussion that we had today will help with some of those discussions that you're having internally and with your own counties. So thank you all for participating in that poll. I've got a few more poll questions I just wanted to run through, and we'll do them sort of quickly because I'd be interested in knowing who's on the call. So maybe we can sort of launch those polls, and if folks want to participate in that. Great, thank you. And let's go to the next one. Thank you. And another one. Okay, and the last poll, has your county passed a resolution? Great. Thank you all so much for indulging me. And, you know, I love poll questions on these calls. You know, just a reminder, this network call, as well as last week's webinar, all of the recordings and the slides are available on stepuptogether.org/toolkit. These ones will be listed under question 2, so you can access them there. Give us a couple of days to load this one. But probably, you know, by early next week, everything should be loaded up. So we appreciate everyone sharing your thoughts. As a reminder, we will have an evaluation that's launched for this call directly after I close out the webinar. It'll pop up on your screen. We also send it out over email when we send out those videos. So you will get that in the next day or so. We really do look at those. I mean, for example, one of the suggestions was to move all these polling questions to the end, which we are more than happy to do. So we really do try and look at those and take in your suggestions for making these something that's useful to all of you. So we appreciate it. And then just a reminder for those who weren't on the phone, when we first started, please join us next month for the next series of webinars and network calls on establishing baseline data for people with mental illnesses in your jails. We know that this is something that folks really struggle with, so I hope you'll join us for those. You can register on the Stepping Up website, stepuptogether.org/toolkit. So we hope you'll join us for next month and all of the coming months as well. And here is the contact information for folks who can help you with anything that you're looking for. My contact information is at the top, and we also have Shanice Bonilla at the CSG Justice Center and Lindsay Fox over at the American Psychiatric Association Foundation, or you can reach anybody at info@stepuptogether.org. Thank you again for joining us, and I hope that all of you have a wonderful day.